Morning, everybody, or just afternoon. So the purpose of this session is actually to chuck it back at you and give you an opportunity to ask the people sitting up here some questions. It's probably worth it if there are a few of us you may not know. Tom's obviously introduced himself. Is there anything else you want to say, Tom, about yourself?
No, that's good enough, I think.
So I'm Andrew Goddard. I'm president of the Royal College of Physicians, but I'm a gastroenterologist in Derby, which is how I first got into understanding about GS1 through how we implemented changes in our endoscopy unit, which I came to speak about at the last conference. To me, I think that we live in a world where there are so many things happening with technology and information in the NHS. We have to rely on standards as the means to keep it all safe and make sure that everything works together. I think one of the challenges that I would say is that you can get doctors enthused, you can get managers enthused, but we need to get patients enthused. We need to get patients to understand, and I think the wristband is a rallying call, perhaps, because if every patient realises that the wristband should be the same wherever they are in the country, that's something that we should perhaps do. I think it's fantastic that we can map the genome. I think it's fantastic that I can know what my risk of prostate cancer is when I'm 65. However, I think it's not so fantastic that when people come into my hospital, I still know what medicines they're on and what their diagnoses are. So I think we've got quite a long way to go, but there are challenges. So that's me.
I'm Lorna Wilkinson. I'm Director of Nursing at Salisbury NHS Foundation Trust. And Salisbury is one of the 6 demonstrator sites for Scan for Safety, and I am the executive lead for that programme. And I agree, but with everything that you've just said, I think in terms of, you heard a lot of this morning about how the programme brings together that patient safety element, that ability to look forward and reduce clinical variation through the transparency that we get in that real-time data, and also the efficiency gains. And again, heard this morning how we're living in a constrained financial climate, and for every pound that we can make that go further, that has to be better for patient care. So I think it's a really unique programme of work, and delighted to be here talking about it.
Hi, I'm Whittle. I'm a nurse and one of the CCIOs at Leeds Teaching Hospitals Trust, and I'm the nurse lead for Scan for Safety. Again, absolutely agree with everything that's been said. For me, Scan for Safety has been a real enabler to help us work with our clinical teams to think about how they can use technology differently and how it can empower them to work better and to engage differently with patients. And that's really important. I think we've heard a lot this morning about how technology is going to support care. But what we've not talked a lot about is how do we ensure that our staff are digitally literate? And for us, Scan for Safety and bringing that technology to the bedside is the first step on that journey for some of our teams, and that's really important.
I'm Terence Stephenson. I'm a Professor of Paediatrics at University College London. And at different times I've had roles in the National Patient Safety Agency, the MHRA, and the European Medicines Evaluation Agency. So I'm kind of interested in this whole theme of using data to make the practice of medicine safer and more effective.
Okay, so I'm conscious that there's a great light shining on me and I can't see it. But does anybody have any questions to start the ball rolling? But Tom, do you want to talk about the role of NHSX?
Oh, right, okay, yeah.
New thing.
Great question to start, thank you. So first off, I think NHSX is a great initiative. And why do I say that? Because from an NHS Digital lens, having the Department of Health and Social Care lead on digital policy and NHS England lead on digital strategy felt a bit kind of confusing, and therefore having both organisations and the digital policy and the digital strategy function subsumed in NHSX, I think creates a really great opportunity for clarity of leadership, for effective commissioning of NHS Digital, and given the long-term plan and the ambitions in that will certainly need absolute top-quality strategic leadership, strategic supply management, strategic data standards adoption kind of influence. And I really see NHSX as being the organisation to provide that. So I think it's something to be. We'll obviously have to keep an eye on it, but I think NHSX is a good thing, and look forward to supporting it to succeed.
Are you guys happy you understand what NHSX is and where it's going to take us, Lorna?
I think it's emerging. And I think for our teams that will be the case as well. So Yeah.
Yeah.
So I was involved with the Academy document that you talked about. We were sort of looking at AI and technology things. And I think the key message that lots of clinicians came up with, the thing that frustrates us the most, which NHSX has put at the top of their to-do list, is interoperability. And the fact that we have so many different systems that don't speak to each other. And I loved your last slide of the, of the various ways that we can all plug together and how GS1 fitted in that. And I think, to me, that is, you are like one of those sort of dongles that has all the plugs on.
Right, yeah.
That you can plug in and actually then everything can talk to each other. Yeah. Any questions? Yes, at the front here.
I'm Lynn Hodgson, Director of Finance for North East Ambulance Trust. We all know that technology allows us to do an awful lot, but what I find quite frustrating, having been in the NHS for lots of years, is despite some of the fantastic initiatives we've got and some of the ability that we've got, we don't seem to be able to roll it out at scale, and I think GS1's a good example of that. And I feel we miss sometimes in talking about the digital enablers, about the culture and what it means to people and the fear that people have about technology taking away their role in their job or changing their job. And I just think we need to talk a bit more about how we can handle that and include that in some of our strategies. So I would just like your opinion on that, if you don't mind. Thanks.
Jackie, you talked about getting the workforce literate, and that sort of covers that a bit, and the fear of what this threat of AI and new technologies.
Yes, and I think it would be a wonderful world, wouldn't it, if we just had one transformation project running at a time that we could all focus on and we could all work to embed. That's not our life, that's not how we work. So I think one of the things that we've tried in Leeds is to look at the varying transformation projects we're working on and link them in together. So we don't talk about Scan for Safety as a standalone project. Scanning is embedded in how we're developing our EHR and how we're bringing technology to the bedside. So staff feel better talking about something when they can touch that change and when they're physically involved in rolling it out. And I think what we've tried to do is set up early implementer sites where staff and encourage staff to go and look at it, but really focus on the positives and the benefits that it brings. Because I think we've got to think about the value added. And if staff can't identify the value added, they won't adopt it. And I think what history's taught us is clinicians are really good at putting workarounds in. And they will find a way of working around it. So the easy way should always be the right way, because that's, in a busy clinical world, that's what will get adopted.
And it's, so there is a difference between different types of staff. So in my endoscopy unit, the guys in the disinfecting room and the nurses are far better at sort of obeying the rules, so to speak, and they like that, than the doctors. How we get the doctors on board is we give them a list of who's the most successful at doing stuff. And you introduce a bit of competition, and then that gets them engaged, and different drivers will work. Terence, on a national level, is there, what lessons can we learn?
I agree with your point completely, and I too am perplexed at the difficulty the NHS seems to have in adopting IT that all of us use in our daily lives. For the last 4 years, I was chair of the General Medical Council, which is another body that deals with very secure data, has a lot of staff working in a distributed way. So rather like the NHS, has never been hacked and never crashed. And I wonder if part of it is just historically a lack of investment in IT and IT expertise. Inevitably we put a lot of our resources into caring for people, doing operations, treating them with drugs. But I was very struck at the General Medical Council how IT security, ease of working, ease of interoperability was absolutely at the heart of it. And hopefully, with the priority in NHSX, we'll now see that start to happen front and centre of the NHS in the same way.
Thank you. So just to reiterate, that's not a challenge to people in the room to try and hack into the GMC website. Lorna, do you want to say anything on this?
No, I'd agree, really. I think what we found is really the ease of use, and that's what was made this quite unique. So I think Terence talked in his earlier session around the clunky systems that I think we've all lived through. So IT and digital systems do have a bit of a bad reputation certainly in the organisations that I've worked in, and I think the ease of this and the ease for the user and that real-time data. So talking about different hooks that Bod talked about, for our clinicians, it's that real-time data and that usability of that dashboard. So I think the ease of use, the value that they can see that they're getting out of it. And to be honest, in terms of people and their threat around roles and jobs, I think what we found is people are so crowded out with tasks within their jobs. This is freeing them up to do what really matters to them, and they see again that adds value. So it's been, and it is, a great sort of piece of work to sort of be involved in. And I agree with Jackie, it's about how do you integrate that into everything that you do. And I think as a demonstrator site, you know, we started off with the scan for safety tag. Now we're at that, hang on, CIOs and everyone else, how do we just make this part of business as usual and integrate it into every time we're thinking about technology? Does that answer your question?
I would also say that this, you know, for all, you know, Hunt was very much about patient safety, and so he sort of got what we were talking about when it came to patient safety. Mr. Hancock's much more about how do we get the best from new technology, and you know, so I think we've got to ride that train, and that enthusiasm is great to see, but it might just need a bit of harnessing, and that's why we need the likes of Tom just to give all that data and evidence, and we need some really good examples of how it's made a difference to patient safety, because politicians, they like data when it supports their argument, but if you want to convince people, it's anecdote and it's human stories, and I think that's what we've got to try and work on.
Good morning, I'm David from P3 Medical, so on the supplier side. Just on my side, I'm more interested in when you feel this would actually start to become the normal and more trust would pick it up than just the demonstrator sites. I think GS1 is a great initiative, especially from our side, because we want to see where our products are used, who's used them, and if something does go wrong, it makes it a lot easier for us to have the data come back to us and showing where it's been used and how we can help fix the issue in future to what caused it. And it would be great to see that used across all of the trust, not just the demonstrator sites.
I think the history of the NHS probably tells about 10 years. But you know, to roll something out at scale across the NHS will be difficult. But there are timescales that NHS Digital is working to.
Yeah, well, and I guess we support our partner organisations on things like the Scan for Safety programme. But in terms of the contract, I think Glenn has maybe asked me to say a few words about it. So we've signed a 5-year term. We're spending about £500,000 of our money per annum on the GS1 licence to support wristbands, graded clarity of use, to support CIO accountability, and to have the geolocator number service, the GLN service. And it was one of those kind of buy decisions where do you ask every single individual NHS trust to negotiate separately with GS1 or within a framework, and just the transaction cost of that would have probably been £500,000 per annum alone. So we've contracted a 5-year term, so that gives the next 5-year chunk of the programme, and we'll have to see what we can achieve within the 5 years.
I mean, there's both, as you talked about, top-down and bottom-up. So if you can get the trusts asking for it and seeing the successes through peer learning, that's a good thing. But also having a bit of a carrot and stick from the top helps hugely. Any comments on that?
I mean, I would say there's already been hospitals on this, style providers on this stage who weren't demonstrator sites. So I think that signals to me that feels quite new compared to previous years, that we've got some hospitals that are quite, really quite advanced. They weren't demonstrator sites. So number one, I'd say they're here. That's really positive. Number two, what I'm hearing more and more is that we are working with integrated sort of systems for health and social care. And certainly it feels like there is a real emphasis within the demonstrator sites to spread this work across those systems. So I know in Yorkshire that's happening, certainly in Wiltshire, the STP that I'm from, that getting all of the core enablers within all of the 3 acute trusts within that area, that work is happening now. So I think it's probably not happening as quick as you want it. I think we've got some national timelines to work to, and certainly there's lots of work on the ground spread through our provider systems.
Some organisations are better equipped to go straight because they're financially fit and they can focus on this, and they've got some headspace time to do some transformation. The really struggling organisations who are in STPs, which are also causing lots of rearrangement, and they've got lots of other pressure on them, they will need some support, and therefore I think we just have to accept that. But if they see the positives, then that will be an encouragement. So there was a question over on that side of the room. Yep.
My name's James Hayward. I'm CCO at Western Sussex Foundation Trust. Something that's interesting me is sort of local solutions to these challenges and these compatibilities are being developed. But one of the things that we're also talking about is the development of the cloud and taking a lot of the infrastructure services off-site. And it feels like that, if there was a sort of exemplar, or if that was taken on in the same way as the sort of the spine's been taken off BT, could we not accelerate the change by saying, look, these servers exist, the infrastructure exists. If you stop developing local servers and things like that, you could start chucking out tow ropes to organisations that are struggling. And it strikes me that's something that would make things go faster.
And by the way, I'm a big fan of Western Sussex Hospitals, having grown up in Stenning, which is within your catchment, and I'm off there for Easter. So I guess what we've done so far to support that is, I think it was last January or February time, we published some cloud guidance for NHS Trust to create a framework for decision making to determine whether they want to use cloud or not. And I think that was, as I understand, that was very well received. In terms of providing, I don't know, a framework contract or something for cloud capacity, I mean, that's something we could look at. I guess it's, I'm thinking some of my platforms and infrastructure colleagues who are here, that's nothing I've seen on our kind of books to progress at the moment. But it's kind of one of those things, if there's a demand, and we'll aggregate that demand, and then we'll have a conversation with NHSX to see if it's a thing which we need to support the NHS on.
Have any of you come across the sort of the not invented here, therefore not going to use it sort of mentality? Yeah. Terence?
Yeah. Well, I think people are still scarred by MP Fit, so there's a sense of people do want to do things locally. I don't really mind that. I think the key bit, which both Tom and Bod have already mentioned, is this thing about interoperability. So I don't mind people coming up with their own systems as long as I can transmit to them and them to me. It does seem bizarre that if I'm in the emergency department seeing a child, the GP has to phone me, tell me the name, date of birth, I have to write it down in a pen. Why can't that just appear on my screen as I go to see them? And then likewise, when I discharge them 3-4 days later, immensely frustrating to print something out and put it in an envelope and give it to the parents and say, can you drop this off at the GP surgery? By the time they get it, they're seeing that patient and why can't they? So that whole thing about interoperability is key. Otherwise, I don't mind people coming up with different things. I think that's innovation, that's fine.
Jackie, do people come to you and say, I've got this great idea, how do I make it work?
Yes, and I guess one of the...
And are they great?
one of the challenges we face is quite often we get presented with a solution. And we want to co-produce with our clinical team, so we would rather they bring a problem and let's solve it together. Leeds is self-building its EHR, so we have a different set of challenges, but immense benefits from that process. So, like yourself, we want to look at other systems. If we can do it within our established EHR, then great. But if not, or we can't do it in a timescale that's appropriate, then let's bring the best technology in. But it has to talk to our system because we can't have our clinical teams logging in and out of different systems. Yeah. Those days have gone. We can't progress that.
So I foolishly agreed to work with the MHRA on a clinical advisory group about new technologies. And I think one of the biggest challenges we have is that there are so many things around, and a lot of the industry that's involved have investment to get started with stuff. They'll do it, and they move on to something else. And the NHS just doesn't work that fast, and patient safety can't work that fast. So I think we do have lots of challenges about how we solve the not invented here, the huge multitude of things that are, the ideas that are out there. But in some ways, you're right. If we can get a library of great things that work, that almost have been peer approved, and then we can then roll them out, I think that's a good way to move forward. So you didn't get that question. She works as a pharmacist in North West London and asked the question about, is it a good thing or a bad thing to have outsourced IT services? Any experience on the panel? We don't have any experience.
Yeah, okay, thanks. so it's one of those answers where it depends. Yeah, I guess it depends where your IT function is in its kind of maturity. It depends whether you want to outsource a little bit of or all of it. and I guess I've worked in an environment outsourcing major contracts and then also insourcing stuff. So I think there's not one right answer. In fact, I can see there's some great CIO colleagues in the room who will be able to give you some informal feedback. I guess the things I would look for would be accountability, control, and being really wary of skills degradation within your organisation. Because I think if you outsource, say, lock, stock and barrel for some, then you will suffer a skills degradation. You'll probably get very well skilled on contract management, but if there becomes a point you want to either in-source or multi-source that provision at a date in the future, you'll then have a big skills building task. So it depends. It also depends geographically where you are, local job market conditions and others. So.
And it's ensuring the organisation has resilience. I've been burnt a bit within the college whereby we've contracted out, and then 5 years later when we've looked to renew the contract, there is no future in that, so we've had to find another provider.
I'm very interested, Tom, on your opinion. There's an assumption that artificial intelligence, machine learning, natural language processing is the way to go. But the challenge in retaining and acquiring data science talent with FSI markets and so on is already quite apparent. I've spoken to a number of acutes and secondary care providers who suffer with that lack of skill set. So I'm keen to get your perspective on how NHS Digital, NHS England, NHS Education are working together to address what could become an insurmountable challenge if not addressed very, very soon.
So whilst you're having a think, so just ask the audience then, how many people have had problems trying to find appropriately skilled people in the field of IT for their trusts? So a small number, but a significant. That's Tom.
Sure. So there's probably a couple of things. There is a conversation being led by Health Education England and James Freed, the CIO there, he's a great system thinker, and he's got together all of the arm's length bodies of which NHS Digital is one to examine the problem, and that's kind of linked in off the back of the Topol review. So there's definitely a kind of piece of macro diagnostic work ongoing led by James and HE, which we massively contribute to. Then kind of at the other end of the spectrum, this is where I think UK Research and Innovation and Health Data Research UK comes in. So I mentioned the MSc programmes which HDR UK are busy putting in place, and I'm actually on the evaluation panel for that week after next. And we really want to increase, absolutely the net increase in the number of MSc grads in health data science skills coming through the system. And then I think we've all got responsibility as employers to, and hey, the NHS brand is a wonderful brand. We may not be able to offer the salary points as FSI industry, but we can certainly do something much more socially rewarding. And we've actually hired a couple of members of staff who've worked for big investment firms in the city, and they actually want to join the NHS because of the strength of our brand and the purpose of their day-to-day work. So I know that won't cover everyone, but so in summary, your party group, which is working, really driving the MSc activity, I think there's employer branded strength, and I think looking at your apprentice levies for NHS organisations as well, and seeing what we can squeeze out of those as well.
Anyone want to chip in there? I mean, I think the other thing is that the public don't really understand when everybody talks about AI, and talked about people don't understand what NLP is, and also that a lot of people think that the AI technologies being used for medicine are AI, and they're not. They're just algorithm based, and we're still quite a long way from those more stochastic sort of thinking programs, but they'll come. And I think Terence was right that at the moment it's very much the image, and you can see how it might work for radiology, and you can see how it might work for skin lesions and stuff like that. But actually, when it comes to differential diagnosis, we're a long, long way off.
Hello, hi. I'm Sue Bracey from University Hospitals Plymouth. I'm the integration manager there. So interoperability is very big for us. But my question is around EPCIS. Electronic Product Code Information Services. So it's part of the GS1 standard, and it's a way of collecting event data. And I just wondered if this is on the NHS Digital's agenda anywhere. We have actually hooked up with NHS Digital. We spent a year trying to get some national interest in this, and we're also working with InterSystems, who are a big interoperability company, and GS1 to put a pilot forward, but we've really struggled quite a lot getting it off the ground. And I just see this is a solution for pulling all that data together in a standardised way that can be used across all trusts. We're looking at building an app against it, which the idea being it could be used in any NHS trust that's doing GS1. And the event data is a byproduct of that. So all that information you can collect in a standardised way. I just wondered if it's at all on your agenda at the moment.
Sounds like a no-brainer to me, Tom.
Yeah. And who are you working with in NHS Digital?
We had a meeting.
Why don't you two touch base? But I mean,
we had a meeting a while ago, but it was just as a sort of kickstart, and we agreed to do a pilot. They've not had a huge input into it. GS1 are involved in InterSystems. We'll see them later today here for taking it forward.
Yes, I'm pretty sure it's not a standard which we're consulting on as part of the standards framework. So I'd love to have a conversation over lunch just to find out where you're at and how we can take that forward.
Right, brilliant. Thank you.
It's Caroline Beecham from Becton and Dickinson, and I've got a question around data analysis. So we saw this morning how far we have come in computer technology and collecting data and how it can help us. But what is going on in the trusts to actually put that data into information that can really drive patient outcomes? Because you will have to have someone who will analyze these masses of data that we're now capable of harvesting. And so I'm just interested to hear, who's going to do that? And are you hiring people, or is it again then doctors and nurses' time who sit there freed up from running around getting the data, now analyzing it?
So apparently the 1.4 megabytes that every person on this planet generates in data every second. How are we using that sort of information in the NHS, Lorna?
So in terms of, in our trust, the clinical dashboards, they are created using software and an information team in-house. So no, we're not outsourcing that, and it's not clinicians who are having to do the bulk of that work. Obviously then clinicians can use that data and they can cut it in various ways, by consultant, by group, by procedure code, etc. So they can then manipulate that data for their own sort of review and purposes.
Jackie?
I think most clinicians would say the important thing is that the organisation owns their own data and they have to have access to that. For us, the key step that we've taken is our links with our academic colleagues at the universities. So all our data is hosted within one of our academic institutions, and we work closely with research partners within the universities to help cut that data how we want, move it forward to inform policy and population health going forward.
Terence, you want to say something?
Yeah, I think there are two streams to answer your question. One is universities or academic centres, and I showed some data this one where researchers, dedicated researchers, are often using big data sets across the whole of the NHS or across multiple hospitals and trying to answer research questions. I think at a more limited level, of course, you would expect individual trusts to be using their data for continuous quality improvement, what used to be called audit, I suppose. One of the things I've been struck in moving from Nottingham to London 10 years ago is that in London, when you're looking for informaticians or data scientists or analysts, you're competing with the City of London, banking, a lot of big national offices, and it's competitive and it's hard to match those salaries. And I think that remains a huge challenge, certainly working in London. More generally also, all over the country, there's that tension between will people come and work for the NHS over someone who would pay more. I think that will be, I think Anne Slee was hinting earlier, that's, I think you're right, one of the potential hazards is we're awash with BOD's data, but we don't have the expertise to use it. And that, I think, is a real risk.
Yeah, no, if I may add, something we're intentionally doing at NHS Digital is something called pushing up the baseline, because it kind of breaks our hearts how a number of NHS organisations are paying quite a lot of money for some quite basic data analysis. So we want to, the data we hold in trust, we want to make it available, obviously on a secure basis as much as possible. So kind of pushing up the baseline, and we've got a GP data portal where practices can go and look at their comparative performance. We push some of the data through to the NHS Improvement Model Hospital dashboard. There's a social care data portal as well, and all kind of almost everything we receive, we should be able to play back into the NHS, and by doing so, Trust can still spend money on data services and consulting services, but hopefully on higher end activities and not just fulfilling the basics. So that's what we're doing.
I think that comes back to the earlier point about doing everything locally, or so where you need a lot of expertise, it would make sense to employ that centrally, develop something, and then let everybody use it. Whereas at 300 trusts reinventing the wheel, going to be pretty amateur, I think.
Mm.
So could I just say thank you to all the panel members for their advice?